graph we were showing that numbers have jumped needs to be read together with this slide, which shows us that 36 countries still have less than 5,000 cases. Why do I emphasize this? It is because those 36 countries still have a very huge chance of not only flattening the curve, but interrupting transmission so that it is not countrywide, because the numbers are still relatively manageable at less than 5,000. So if you look at our 55 member states, 36 of them have cases which are less than 5,000. So Africa still has a very good chance of ensuring that the vast majority of the countries can be able to control transmission within their own borders. The one country is above 100,000, that is South Africa, and the one country is between 50 and 100,000. So we see that the drivers of the huge numbers we are seeing in Africa are only a few countries, and so it means we still have a chance of actually being able to control this particular pandemic on the continent. Now, when you look, let me go back here. When you look at these numbers, I must emphasize that these are cases that have been confirmed by laboratory testing, one, and secondly, they are numbers according to what the governments are reporting to Africa CDC. They have an obligation to report to us, and so they report on a regular basis. We collect data twice in a day. We collect data throughout the day, throughout the night, but we report it twice in a day, at 9 in the morning, and then again at 6 in the evening. So the data that we have is what has been confirmed by countries to be the data that they are reporting. If a country is not reporting, then of course the numbers will be a little bit different. But these are cases that have been laboratory confirmed. And this transitions to the next slide. When we look at the testing on the continent, we see that first WHO advises that a country should do at least 10 tests for each case that they have. So the test to case ratio should be a minimum of 10. The higher you raise that number, the better it is for a country to know what its burden actually is. Now, the positivity rate across Africa is at about 10.5%. And this simply tells us that although we are doing targeted testing, we have not refined the way that we are doing targeted testing. If the positivity rate rises to something decent like 15 to 18%, then a country's ability to target testing is, we can say that it is much, much better. But globally, in as far as the continent is concerned, we are 10.5%. We would like to see that number go up as countries target their testing. Now, during April, what we did as Africa CDC to enhance and support countries in Africa to do more testing, we launched an initiative that we called a partnership to accelerate COVID-19 testing, in short, PACT. Now, PACT has 3 components. The first is test, the second is trace, and the third is treat. Under test, what we committed to ourselves from April is that we will have 10 million tests be done in Africa by October. Now, we are already above 8 million, and we are only at the beginning of August. So we are quite happy with the way that we are progressing with supporting countries to achieve that particular target of testing. What we are not happy about, you see the next slide, is this test per case ratio. So if you look at all the countries, you will see that 3 countries are doing very well. They are doing over 100 tests for each case that they have. And this test per case ratio of over 100 is really unique and usually associated with the relatively smaller countries because they have fewer population, and so they can be able to do much more in as far as testing is concerned. But if a country organizes itself, the resources are there, and they can be able to reach these high levels of test per case ratio. Of concern is that we have 27 countries, just about half of the countries on the continent. 27 countries are still doing less than 10 tests for each case that they have. And if you look at the map, these are largely the countries in Central Africa region and a large swath of the West African region. The other regions are relatively or better represented in as far as testing is concerned. So the whole of this region here, which is the Central Africa region, represent a very large chunk of the 27 countries that are still doing less than 10 tests per case. The other countries are all within range. They are above 10 at least, and this is good progress. And if we look at the full range of the 55 countries, the least testing, and I will not say which country that is, you'll forgive me, the least testing is at 2.8 tests per case. Very, very low compared to the recommended 10. And the most that is being done is at 596.8 tests per case. So it tells you that Africa is seeing both extremes, those who are doing very few tests and those who are doing very well in as far as testing is concerned. You win or lose your battle of COVID-19 around testing. If you test enough for your population and exposure, you can be able to interrupt the pandemic by then instituting appropriate public health measures and other administrative measures to be able to protect your population. So this part is very critical, that we are working very hard to try and get this part, the Central Africa and parts of Western Africa, to do more testing and increase their test per case ratio. While we are still here, let me say two other things about the two other pillars of our PACT initiative. That is trace and test and treat. Now, in trace, what we have done as Africa CDC is provide support to the countries in Africa in three major areas. The first of those areas is to ensure that we have professionals supporting ministries of health with epidemiology, what we call disease intelligence officers. So we have provided around 22 countries now and growing with specialists who cover different aspects of the pandemic so that they can be able to provide support to those particular governments. The second area is community health workers. Our intention is to have 1 million community health workers participating in tackling COVID-19 on the continent by October. And as Africa CDC, we intend to provide 100,000 of those, while governments and other partners, we are encouraging them to fill the gap. Ours is really proof of concept. We are providing seed support, and then governments and other partners are filling in the gap. For community health workers, we are already in about 27 or so countries, and we are expanding as we go along. Then the third area, in as far as surveillance, the trace aspect, pillar of is concerned, is supporting countries to do surveys. And these are targeted surveys. We are shifting into the area of, can we understand the pandemic in each country? And to do these surveys, we are using serological platforms. These are rapid tests. We are not using the PCR-based laboratory testing platforms. We are using the serological rapid test surveys so that we can be able to understand the pandemic more. And what we are using for the rapid test is antigen-based rapid test kits, so that we start with targeted groups like health workers, and then we'll go on to better organized communities, schools where they are open, and disciplined forces, for example, because it is easier to do those testings in those groups. But then we are moving on to communities, supporting governments to move into communities so that we can be able to do sero surveys, and we get to know the burden, the true burden of COVID-19 in the community. The reason we are doing this is we want to pick people out early so that they are able to be isolated, and we see if we can be able to rapidly interrupt the transmission at country level. So this is the third aspect of the trace component of our PACT initiative. The last one we'll be able to see shortly. Now, in as far as providing support to member states is concerned, we are doing a lot for infection prevention and control, IPC in short. And we are doing trainings. We've already done trainings at the continental level where we bring in our subject matter experts, and then they go back to their countries, and then we do step down training. And this we've been doing, and every 2 weeks we do a set of countries. We support a set of, and we've been doing this since April. So we are quite far down in covering literally all the countries on the continent. We hold regular webinars. And these regular webinars, we do them 3 times every week. And this is to provide remote support to professionals who want to hear more about infection prevention and control, what is new, and how the governments can be able to work with Africa CDC to strengthen their own infection prevention and control programs at country level. And we are not only doing it for professionals, as in medical professionals, we're also doing it for journalists, because then they can be able to communicate some of this material in an organized way. We have guidelines. I'm sharing that website again. There are guidelines that are very useful for health professionals and other members of the public. There's a lot on that website. Now, the treat component is one that is becoming more and more important, particularly in sub-Saharan Africa. The reason being that we have few health workers. And the few health workers that we have, we want to protect them and to make sure that they can be able to provide the service that they are trained to do in an environment that leaves them functional. We don't want them to get sick. And right now we are seeing an increased number of health workers who are not only getting sick, but we are losing some as well. And this is a situation that we don't want. So we want to train and provide updated information to our clinical experts. That way they can be able to do their work in an organized way. Up to today, we've already done about 9,000 clinicians, and we continue to do these web-based trainings because face-to-face has become difficult due to travel and other restrictions. So for the clinical case management part, we are doing that kind of training. And all this information is on our website, how you can be able to join any of those webinars. If you follow us on Twitter, LinkedIn, Facebook, and all the other social media platforms, we share these on a very regular.
Something is happening. We can't hear you, Doctor. We've lost, it seems like we've lost Dr.
I'm back.
Oh,
Yeah, it keeps on falling off, so you'll bear with me a bit. Can you hear me now?
yes.
Yeah, very well. I was saying that we do in a graduated manner supporting the most vulnerable countries, and then we come to the less vulnerable countries. One key thing that we have done during the month of June upwards is that we put together, and this supports case management, we put together a continental conference on COVID-19 vaccine. And we have a strategy that we've developed already of how to secure vaccines for Africa. And now we are taking the next step of preparing for the vaccine to be rolled out in Africa, because we know the vaccine will be there anyway. One big problem that we found with the vaccine programs in Africa is that there's always a lot of negative perception with the whole concept of vaccination. And so we are putting together a study to understand if the African is ready for the COVID-19 vaccine. And this vaccine perception study is going to be rolled out shortly in collaboration with the London School of Health and Tropical Medicine. For lab, I think I have already captured this quite well. The two things I would like you to see from this slide is that only a few countries, 10 countries, are actually contributing to almost 80% of the total tests that are being done in Africa. And this reflects very well with the conversation we were having that Central and Southern and Western Africa are not doing enough testing. 5 countries are actually contributing almost 64% of the total testing that is going on. So it tells you that we still need to do a lot of work of getting the countries in Africa to do more in as far as testing is concerned. And some of the things that we've done to try and increase the number of testing is around using gene expert machines. These are platforms that are relatively easy to use, not the open platforms that need a lot of expertise in as far as laboratory professionals are concerned, to try and increase. And gene expert platforms we're already using for TB, for HIV, and all we need are the cartridges that are going to be used for COVID-19 testing. And this, we believe, is going to improve the way that we do our testing, particularly in those countries that are lagging behind. I want to quickly flash this, that starting the 7th of August, we have one whole week globally, which is themed as World Mask Week. The theme is My Mask Protects You, Your Mask Protects Me. So please follow that particular hashtag, World Mask Week, so that we can all be able to share why we need to wear masks and why masks are important. Those key points, I think we all know. How to participate is something that we'll be able to do at country level. 2 last things that I would like to say before we open this up for discussion is around clinical management. The first is hydroxychloroquine. We've had a lot of information about hydroxychloroquine globally. Unfortunately, the much debate that has been there around hydroxychloroquine is providing so much heat, but there is not much light that is coming out of it. And our position as Africa CDC is we have been following about 5 or so, there were 7 initially countries on the continent who are doing, who are using hydroxychloroquine for treating critically ill patients. 2 of them are no longer doing it at all because the results they found were not encouraging. The other 5 are not using them, are not using hydroxychloroquine as one of the first medications to use. They're using it for the less serious cases. Uganda, a good example, DRC as well. And even there, the results are not earth-shaking. It is not something that would change the way that they handle their cases. So as Africa CDC, all the evidence that we have gathered globally and particularly in Africa does not convince us that hydroxychloroquine is a game changer in the management of COVID-19 cases. We see its place in managing malaria, of course, but there are better drugs out there now. But we do not see its place in the management of COVID-19 at the moment. When there comes evidence, we'll be the first ones to step out and say this is a good thing. As a public health and a science-based organization, we base all our guidance on solid science. We base all our guidance on evidence, and we base all our guidance on the best interest of African countries. And for now, hydroxychloroquine is not one of those that is giving us any sort of confidence that it can be a game changer. The second thing I would like to say around clinical management is the product that came out of Madagascar. Many people have asked about it. What we have done three things as Africa CDC. One is we engage with the government of Madagascar and we have received all their data. We have analyzed their data, we have given them our feedback. That is the first thing that we did. The second is we have taken the product and it is being analyzed, almost finalized. What is its content? What are the active ingredients? What could be that ingredient or groups of ingredients within that particular product? It's called COVID organics, that would be useful in as far as management of COVID-19 cases is concerned, or prophylaxis or prevention. And that set of information we already have. The third thing that we have done is now we have opened up sites where this particular product is being tested to see if in different contexts it could be able to give similar results. And I'm not saying that similar results are good results. I'm just talking about similar results. If we are seeing a negative result in country A, is it the same in country B? If we are seeing a good result in country X, is it the same in country Y? Because we need the evidence for us to be able to say that from Africa something has come out. But this is not to say that nothing like can come out of Africa. It is possible, and we have encouraged our scientists, we have encouraged our healthcare professionals to document everything that they're seeing around COVID-19, so that that good thing that is coming out, we can be able to share it with the rest of Africa and the rest of the world. And I believe strongly that if we started documenting better, we will be way ahead of trying to get local solutions for not only COVID-19, but other things. And finally, is to say that as Africa CDC, we have also been encouraging local production of all the material that we are using in COVID-19 preparedness and response. We want Africa to manufacture its own masks, its own PPEs of various shades, its own vaccines when that one is found. We want Africa to manufacture its own therapies, or whichever type, not just for COVID-19, but this is a good opportunity for us to do that, but also other illnesses that are affecting us in Africa. Local production is key, not only of products, but also of professionals, so that we have our own data and we can be able to use that data for positive action on the continent. And as I close and open up for discussions, one thing I must say is we are the vaccine. Me and you, when we do the right things, and we know what the right things are, when we do the right things and we do the right things consistently, then we can be able to interrupt the transmission of COVID-19, of SARS-CoV-2, which results in COVID-19, the disease, in the community. We are the vaccine, but we must be able to do the right thing for us to be able to interrupt this transmission. The reason why I say that is because the numbers are increasing in our communities, and therefore our risk is becoming more. The fatigue that we are seeing in many places around the world, including in Africa, when the lockdowns are being eased and the countries are opening up, is something that should worry us as healthcare professionals, because if we go out and we lower our guard, if we forget that now our risk is higher than in the beginning, and we don't do the right things, then the numbers will blow up, and our health systems are already getting overwhelmed throughout the continent, and we need to keep our health systems functional so that we not only address COVID-19, but we also address all the other public, health issues and challenges that we have: malaria, TB, HIV, childhood illnesses, etc. And etc. So we are the vaccine. I thank you. Back to you, Abdul Qadir.
Thank you very much, Dr. Ogwell. I liked especially the last part when you pointed to African solutions, and maybe we are used to getting solutions from elsewhere, but that we work towards local solutions, African solutions for Africans. So very interesting and very enlightening, the numbers and what the CDC does and what is going on that we normal people don't know about. So thank you for that. We have a few questions here. We can start looking at the question. The first one is to kindly elaborate on COVID-19 risk assessment protocols in line to coming up with COVID-19 policy. So this is an issue of policy making.
Thank you. The risk assessment protocols are very broad, and it depends on which angle one wants to take. What we have done as Africa CDC is we have divided the different parts of social policy making into 4 big areas. One is health, the second is finance, the third is transport, and then everything else we have lumped into one basket. And the reason why we have lumped everything else into one basket is because we want each and every sector to pick out their own process of risk assessment. But these 3 that we have highlighted, health, transport, and finance, we feel are the key drivers of getting policy making to provide the required resources to responding to COVID-19 pandemic. Finance, clearly, because they are the budget holders. Transport, because of all the lockdowns that have been done across the continent and globally. And health, because we are the ones who see the real effect, we document it, and then we share it. So risk assessment needs to come from whichever sector, but at the end of the day, there must be a way at country level of collating the assessments that are coming from all the different sectors, and then bringing them together into one document that can be able to guide high-level policy making before it gets into the sectoral policy making processes. And personally, I prefer the sectoral policy making process because then there is ownership. You don't want someone way up to say from tomorrow there is curfew, from tomorrow there is lockdown, without the Mwananchi walking on the street feeling that they are part of it. If you have ownership, then you can be able to control COVID-19 much better. We are also developing a vulnerability index, which we'll share in the next weeks for countries to be able to see where they stand in as far as exposure is concerned. This is still work in progress, and we'll be able to share it, but it will contribute to the assessment at country level, so that each country can be able to develop policies that work for it. What we have seen, however, and what our heads of state have been very consistent about at the Africa Union, is solidarity is key. If one country is doing well and the next neighbor is not doing well, then that particular sub-region is not doing well. But if each country is doing its part, then you find that you can be able to achieve more. So the policy making should not only be at country level, but also within the regional economic blocks and eventually at the Africa Union level. And that is what we are providing guidance for. Over.
Just something maybe you can add slightly on what you just mentioned, the last point on the solidarity between countries in the regional bloc. We have in Kenya different approach from that what Tanzania has until today. So how can we put these two divergent policies or theories together so that Tanzania and Kenya can work together instead of antagonizing each other?
I will not go into a specific country mentioning. I work for the Africa Union, so those are my bosses. But what I will tell you is, as Africa CDC and Africa Union, we are working behind the scenes to try and smoothen the sharing of information from the different countries who are member states of the Africa Union. And we know that there are difficulties in some countries to be able to do this, but we are working behind the scenes to ensure that we get that information. Then we can be able to plan better. That is one. Second is using the REX, East African Community, Central Africa Economic Community, ECOWAS in West Africa, SADC in the Southern Africa. We are working with the REX so that cross-border collaboration becomes easier. And we have made very good progress in the vast majority of the countries. And where there are slight problems, we are also working with those countries who are neighbors to be able to get an understanding and a way forward in as far as working together is concerned. And the key driver for this is going to be the economy. When we talk health, many times it is not taken as, I don't want to say, use the word seriously, but it's not taken as with a lot of weight. But when it comes to the economy, when it comes to trade, then things change. And we are going to be using the trade and economic aspect of collaboration across the different countries to strengthen cross-border surveillance, cross-border collaboration, and we are urging all countries to use the guidance that we have provided as Africa CDC to be the basis upon which they do their national level policy making and developing action plans. But I must say that we have not seen the level of solidarity in Africa as we have seen during this COVID-19 pandemic season. It has been extremely impressive, and it has provided the backbone on which we as Africa CDC has done a lot of our successful initiatives and support and campaigns. The solidarity has been fantastic. Africa started early. If we had not started early, the numbers would be worse. We started early, and although now the countries are opening up, they're opening up with numbers that are manageable, not numbers that are too huge to be able to be accommodated within our health system response. Thank you.
Okay, thank you very much for that. The next question is on vaccine. You mentioned about vaccines. So how is CDC prepared to convince the few Africans' perceptions once the vaccine is rolled out? We've had leave alone the African perception. We've had all the world around that vaccines have a microchip that will do this and do that. So the perception of vaccines is not only in Africa, or we have a different African perception when it comes to vaccine, and then we have the one which is imposed on us from the rest of the world on all these things in vaccines.
Thank you. I think this is a very critical question because that is where we are heading. We are not confident, but we are estimating that by sometime in October, November, certainly before December, we'll have one or several vaccines that will already be in the marketplace, and we aim to ensure that we benefit from that. Now, the problem of vaccination in Africa is as old as vaccines have come onto the continent. And it does not help this time that a lot of conspiracy theories have been spun around COVID-19, its origin and how it is not spreading in Africa, and etc., etc. A lot of misinformation and conspiracy theories. What we are doing as Africa CDC is, one, we are Africanizing COVID-19 vaccine. And what we have done to Africanize the COVID-19 vaccine development process is that all the key vaccine candidates that are out there, we are having the clinical trials sites, some of them being in Africa. One thing I would like to confirm is that all the vaccine trials that are going on in Africa today, and there are quite a number of them, are multi-center trials where it is not only Africa that is being considered for the trials, but also other parts of the world. So what is going on in Africa is also going on elsewhere. We are not guinea pigs. We are just providing a platform to be able to be stronger in bargaining for our share of the vaccine for whichever candidate turns out to be a good and a successful candidate. So we are Africanizing the vaccine development process. That is one. Second is through the study that I've just referred to, we are going out to seek, because the other diseases that needed vaccinations did not affect everybody. COVID-19 has affected each and every human being in the world, including the ones that are still in people's, in wombs. Everyone has been affected. So the perception for COVID-19 is a little bit different from what was there before for TB and other conditions, polio, that had brought problems in Africa and as far as vaccination is concerned. So we are going out early to understand the perceptions so that we design our strategy of rolling out COVID-19 better. And we know there will be resistance, and the way to fight resistance is open information that comes before the rumors arrive. If we wait for the rumors to arrive, then we lose the game very early in the process. So we are Africanizing, one. Secondly, we are doing the survey so that we understand what the perception of the African is, and using that information, then we build a strategy that we know is going to be able to be accepted by the majority of the Africans. We know we cannot be able to do, to have everyone say yes. And thirdly is we are building our capacity on the continent to be able to not only develop a vaccine from scratch, and with pathogen genomics expanding on the African continent, we already have the building blocks to be able to develop vaccines. And we've seen that already. Several institutions within Africa are actually developing vaccines. Ebola is a good example, that eventually go out and are tested by Africans among African communities for African benefit. So we are Africanizing, we are doing surveys, and then we are developing our own local capacity to be able to do some of these things ourselves. It becomes easier when we say this product was manufactured in industrial area in Nairobi, instead of saying that this one came from China or this one came from the US or came from Switzerland or wherever. If it has come from our own countries, then we know and we believe that it will be a lot easier to be able to be accepted by our population. So we have to Africanize it. Thank you.
Okay, the next thing which you also mentioned was about testing, and you mentioned that about 10 countries contribute to about 73 or 74% of all the tests. So why are countries not testing? Is it lack of finance, or is it refusing? They're just refusing to do it.
No, it's not lack of finance. There are several reasons why countries are not testing enough. And I'll just mention some of them because the list can be very different from country to country. So I will talk only about the cross-cutting ones. One is the local capacity to do the test. The process of actually testing for the virus, SARS-CoV-2, is very, very involving and detailed. You have to take a sample. You have to transport that sample in a vehicle, we call it a transport medium, a virus transport medium. And then that goes to the lab where you use an extraction kit. You use an extraction kit to be able to remove your viruses from the whole sample. And then after that, you take it into the platform where you do confirmatory virus testing. All that chain it needs a certain type of system to be able to take it through that process. And some countries do not have those systems to use. And that type of testing is the one that is most prevalent because it is an open system. Now, the second type of testing is around the closed systems, where we use, as I had said earlier, gene expert machines and other platforms from Roche, Abbott, etc., who their systems can only use their testing kits. And these closed systems are very difficult to deal with, because if that particular company does not give you their testing kits, then you can't test. So the open platforms need well-trained personnel. And with some countries, particularly in Central and West Africa, don't have that. Second is that some countries have centralized their testing so that only one lab in the whole country is doing it. It means that your turnaround time will be low, because if you have one machine, you can only be able to do maybe something like 20 to 30 tests in a 24-hour cycle. And that is not enough to be able to reach the numbers that we want. So that is the second, centralizing due to capacity issues. The third is availability of the testing kits themselves. Everyone is chasing testing kits. So those who are manufacturing don't want to give away their testing kits because they need it for their own populations. And as Africa CDC, we have negotiated with manufacturers in Germany, in the US, and in China and South Korea, so that we are able to access our own share of the testing kits. And we are using those to provide to countries. And we have also provided the Africa, a platform for African governments to be able to purchase from these vetted companies. But it's a slow process. So access to those kits is very, very difficult, particularly in the beginning of the pandemic. And now that we have a second wave coming in many parts of the world, it's still a challenge to be able to get the testing kits. The final cross-cutting issue that is slowing down testing is policy within a country, where you find that the ability to accommodate the reality that COVID-19 is present with us is a challenge for some countries, for whatever reasons, whether political, social, or whatever. So it means that they are not investing enough in trying to get the tests to be increased amongst the population. Resistance will be there also amongst the population if they see that the whole COVID-19 story sounds like it is fake. So all those policy issues, particularly political in nature in a country, have also slowed down the testing rate that we are seeing. But as I said earlier, we are dealing with those, and we are working with countries individually to get them to test at levels that are acceptable, so that they can know the exact burden of their COVID-19 exposure. Over.
Okay, it's now more than 7 months since the first cases of COVID-19 were made public. So are the symptoms changing compared to the list of the first symptoms? So what we see today as the symptoms, are they the same symptoms we saw when the pandemic was first made public?
Largely, yes. The symptoms are pretty much the same. There are new ones that are being associated with infection, and those are being added onto the list. But the core symptoms that we saw in the beginning, the headache, the fever, the coughing, the sneezing, those are still pretty much there. They have not changed. New ones like loss of taste and loss of smell are also checking in. Difficulty in breathing is, for certain stages, is still there. So in as far as symptoms are concerned, not very different. Now, here comes the problem for Africa. We are in the cold season, and this is the flu season. So separating normal flu from COVID becomes a very big challenge. Second, there are rains all over Africa now, and with it will come mosquitoes, and therefore Plasmodium will give us malaria. And the fever that comes with malaria, very similar to what we are seeing with COVID-19 cases. So the related illnesses that we are seeing in Africa is making diagnosis, early diagnosis particularly, a bit of a challenge, and this can be able to result in misdiagnosis and therefore continued spread amongst the population. But as I said, we are training our clinicians so that they are able to pick out some of these things quickly. Testing is done in an efficient way, and then those who are found to be positive are secured. That way they are not able to spread the illness. But the symptoms have largely remained the same, and just a few have been added to the original list. Over.
The next question also goes on misinformation. Is the Africa CDC involving clerics and churches in investigating vaccine misinformation?
Yes, and in fact, the whole realm of religious leaders are going to be the core of the first wave of our engagement with members of the public around vaccination, because a lot of the resistance has come from that area, and they are going to be our primary target, so that we engage with them and they appreciate why vaccination is key to many illnesses, including COVID-19. The misinformation we are handling through, we have a rumor tracking system that we have that tracks rumors on a real-time basis. And when a rumor starts being generated, we quickly ask that the affected country to correct the information so that we are always trying to catch up and, where possible, ahead of the curve. But yes, religious leaders are a very key part of not only the survey, but also the rolling out of the vaccine program that we have for COVID-19.
Mm-hmm. So how is CDC ensuring all the cases reported from each country are accurate and true? Do you have a system for that? Or you take it acceptable?
Very difficult question. We do not have the capacity of checking on each and every case. What we have in terms of system is validation and quality control. So all countries, we have a system where every X number of cases that are positive, Y% of those cases are transported, we facilitate that, are transported to one of our reference labs. And we have about 5 reference labs across the continent, so that we check if truly what you found as positive was positive. And we are focusing on positive for now because of the heavy workload that is there across the continent. So we do not have the capacity of checking each and every test that has been done, but we do quality control and validation. And so far, there is nothing that is screaming to say that our countries are providing data that is incorrect. But in as far as the actual data is concerned, if a country were to test 100 positive and tell us, oh, we only have 30, then the proxy for knowing if a country is saying the right thing or not are the ill people, because we know that about 15% will be ill and will require hospitalization. So quick mathematics, we do this and we see that countries are actually giving us figures that are correct. And many times you cannot be able to hide ill people. It will be able to get out. So far, our quality control and validation system is telling us that things are being done well in Africa, and where we pick up that things are being done wrongly, we immediately correct, either by retraining or providing new platforms or ensuring that the test kits are actually being stored and used in the right way. But we have not seen anything that is untoward in as far as data is concerned, but we remain vigilant, watching very carefully the data as it streams from the 55 countries on the African continent.
Okay, the next question is on some legal actions, if there is any legal action that can be action against countries that do not meet their TCR at some stage.
In theory, yes. In practice, difficult. Why do I say this? I'll start with the African context. As Africa CDC, Africa Union, we are a union of consensus. And the decisions are usually made by consensus, and we Africa Union has always avoided going down the path of legal action, unless when it is completely unavoidable. So we follow the same path as Africa CDC. We prod and encourage and discuss with countries so that they can be able to see the value of, as we were saying in the mask campaign, your mask my mask. It's very important for a country to feel that they are actually part of the solution. So when we say my mask protects you and your mask protects me, it is in the same way that we are telling countries that your data protects your neighbor and your neighbor's data will protect you. But I say yes because the international health regulation is an international instrument, legal instrument under the auspices of the World Health Organization, and that actually has the ability of sanctioning countries that are not providing the correct information. This, though, I will leave to WHO to sort out. There's no WHO colleague here, but the practice that I've seen is even WHO and the UN system are hesitant to go the legal way because sometimes it then makes a country even more recalcitrant. They don't provide the data at all, and we need that data to be able to plan. So we use soft diplomacy rather than hard diplomacy. The legal action, I have not seen it being taken in the public health context yet.
Okay, one more question. In Europe, we see that they had all these lockdowns and all sorts of controls, and then when the numbers declined, they started opening up again. And now they're talking about the possibility of a second wave because the numbers are getting higher again, and there's a risk of even higher numbers. So has Kenya opened up very early? Is it very early for Kenya to open up for international flights and everything that is going on?
Commenting about Kenya is difficult, but let me do a global sort of approach here. Because I don't have all the details for how the decision was made in Kenya. But what we have provided as guidance is the following. First, let's see what is happening in other parts of the world. When you open up and you are disciplined, you don't get a bad second wave. The numbers may inch up, but the numbers will not be very big. And I think Singapore, South Korea, Japan have shown that this can be able to be done. Even China, they have shown that this can be able to be done. You must remain disciplined as the country opens up. What do I mean by disciplined? You must make sure that you have a health system that is ready to be able to accommodate cases, isolate them, and manage them appropriately. Second, you must have an enhanced surveillance system that is very sensitive to the symptoms and signs of COVID-19. Indeed, you must have a laboratory system that is ready to test significant numbers. If your ability to test is still low, then when you open up, things can go very, very wrong. So your lab system must be in place and ready to test. Your enhanced surveillance system must be ready to pick out the numbers as fast as possible, and your health system must be ready to look after those who have been identified to be unwell. When you open up and you are indisciplined, as has happened in parts of North America, parts of Europe, it's a recipe for disaster because the numbers will go up. And we've seen it in Africa as well. In some countries, the opening up is done and the numbers just jump up. For Kenya, I hope that they have these things in place, those three items particularly, and the overlying thing is discipline. If people are in discipline, then controlling it becomes extremely difficult, and we are encouraging countries, and we have guidelines out there for safe travel. We have guidelines out there for safe opening of schools. We have guidelines out there for safe opening up of the economy. And many countries have already domesticated those. It's never easy to say when exactly is the tipping point for you to open up. But so long as you remain vigilant and you're able to mop up the cases that come, then you're fine. But if you're not vigilant, and if you don't have the system that can be able to mop up those cases, then for sure it will be a lot of heartache and pain for the population when the numbers go up again.
Mm-hmm. And heartache and pain is what we don't want in the population. I can't see any more questions. So if you still have a question, this is your opportunity to come up with the questions. But some comments, very informative presentation, very informative indeed. Thank you very much for that. While we are seeing if we have one final question from our audience, I just want to inform all the participants that our next webinar will be on 17th of August, and the speaker then will be Dr. Andrew Muruka, the Deputy Director of DOSH. He is going to talk about compliance with regulatory requirement and OSH decision making. So come and we take the director to task on issues related to compliance with regulation and OSH decision making. So if there are no further questions, I'm going up and down the chat to see if I missed anything, but it seems everybody's happy about the presentation. So I would like to thank you, Dr. Ogwell, very, very much for the very, very clear and concise information, something we really needed to hear about. I like very much the way you presented it, and you say that we are the vaccine, so we are responsible for making sure that the disease doesn't spread. For ourselves being the vaccines, that we have to do the right thing, and we have to be disciplined to do that right thing. So that is, I hope that will be the take-home message for the majority here. And then my mask, or this is the Africa CDC motto: my mask protects you, and your mask protects me. So we have to take care of each other, and so that we together fight this pandemic. See a question here: is it possible to review the time for some to be able to catch up, maybe from 6 p.m.? This actually, we normally start at 6:30, but this was a special and extra episode that the timing had to change a little bit, but the normal time we have these webinars are 6:30 East African time. So I'm sorry for those who couldn't join earlier, but we had to make this change, this slight change for this webinar. It was a necessity that we had to do this. But the next one will be as normal at 6:30. Any more questions, comments? Okay, so again, I would like to thank you, Dr. Ogwell, very much, and I hope that together with everybody else, I'm sure here, we hope that we get this pandemic to disappear as fast as possible, hoping that we can go back to close to normal life than we had before the pandemic. And thank you for all the participants who took time and to be with us, to listen, and to ask questions, to be engaged in this. I saw Imran logging in. Imran, do you have? Let me unmute you. Imran. No.
And Abdul Kader, you will forgive me. I need to join another meeting in about 15 minutes.
Yes.
Let me say that it's been a very big pleasure and very good discussion. And yes, I wish OSH Pro all the best as you go on with this series of webinars. Very, very informative usually, and it's our new way of life. So we must make the best of it. So I thank you, and I thank all those who found time to participate.
One thing before you leave, Doctor, is it okay that we post your presentation in our webpage?
Not a problem. Share it as much as you can.
Okay, then you just send me the presentation. We'll share it with the others so that all can benefit from it. So we'll let you go, and you rush to the next meeting, and you hope that some other day you can also join us again and enlighten us more on disease control in Africa.
Inshallah. Thank you, and yeah, have a good evening.
Thank you very much, and talk to you later. Okay, I'm interested in participating in epidemiological research with your organization. Kindly advise. Oh, we missed that question to Dr. Ogwell, but if there are some other issues which you'd like to discuss, kindly send us an email, and we can forward the questions or comments to Dr. Ogwell, and then we'll make them available. I hope you have our email address. So just send us your comments, your questions, and we'll make sure that the good doctor gets them and answer them. So if I can't.
Kindly provide your email address.
Yes, I'm doing that. I'm sending the email address to everyone there. So send your comments or anything you would like, any questions, and we'll forward them, and we'll send you the answer. It's unfortunate that he had to leave for another meeting. He informed me about the meeting earlier, but I hope we had a good discussion. And yeah, if there's is there anything else you maybe? Any more questions? As I mentioned, the next webinar will be on 17th of August with Dr. Andrew Muruka, the Deputy Director of DOSH. So if there's no further questions or comments, thank you very much and have a nice evening, and see you again soon in the next webinar on 17th. This presentation and this recording of this and the presentation will be put in our web page, the same place where you got the link to join in. This will be posted there. So until next time, have a nice evening. Take care of yourselves and your families and your neighbors and friends, and let's fight this pandemic together and win together. Thank you very much.